Good morning again. I will be talking about Irving-Gass syndrome and hemorrhagic occlusive retinal vasculitis. Alexander Irving was the first to report in 1953 this syndrome, mentioning vitreous syndrome following cataract extraction. Then in 1966, Gass and Norton demonstrated cystoid changes on fluorescein angiography. This is the most frequent post-operative complication following cataract surgery. It can be classified into clinical, subclinical, and angiographic. Clinical with detectable visual impairment, and it reaches up to 4% post-operative. Subclinical, it is detected on OCT with otherwise visually asymptomatic patients, and it reaches up to 10%. Angiographic, detectable leakage on fluorescein angiography in otherwise visually asymptomatic patients, and it reaches up to 70%. What about the pathogenesis? There is retinal capillary dilation, serous fluid in the outer plexiform and inner nuclear layers, with inflammatory cells in the iris ciliary perivascular complex, making the inflammatory mechanism or theory is the main and the current theory. What happened? The surgical trauma leads to release of inflammatory mediators like prostaglandins, cytokines, and vasopermeability factors, which leads to interruption of the inner blood retinal barrier by increasing the permeability of the perifoveal capillaries, leading to intraretinal fluid accumulation, subretinal fluid accumulation. What supports this mechanism? They found that the patients with severe anterior segment inflammation have more pseudophakic cystoid macular edema, and also the patients with pseudophakic cystoid macular edema has more AC flare, and there was alteration in the protein composition of the vitreous fluid. Vitreous extraction and phototoxicity are unlikely now to explain the mechanism. What about the risk factors? We have systemic, ocular, and intraoperative risk factors. The main systemic risk factor is diabetes mellitus. It increases the risk of cystoid macular edema even in the absence of diabetic retinopathy. But if any grade of diabetic retinopathy is present, it increases the risk to 6.23%. Systemic hypertension apparently increases the risk as is a risk factor for retinal detachment. Also, a drug called imitanib, which is used in chronic myeloid leukemia, increases the risk of cystoid macular edema. What about the ocular risk factors? We have uveitis, history of retinal vein occlusion, retinitis pigmentosa, epiretinal membrane, absence of BVD or incomplete BVD compared to patients with complete BVD, YAG posterior capsulotomy, prostaglandin analogs used in glaucoma patients. Also, the anti-glaucoma drops in general have the preservative benzalkonium chloride, which increases the senses of prostaglandins, leading to what's called pseudophakic preservative maculopathy. What about the intraoperative risk factors? Intracapsular is associated with more incidence than extracapsular. Ruptured posterior capsule, ocular hypotony during phacoemulsification, excessive phacopower, vitreous loss, vitreous prolapse to the wound, and iris incarceration. It was reported that the iris fixated IOLs have the highest incidence of pseudophakic cystoid macular edema. Also, it was found that intracameral cephroxime is associated with higher incidence of cystoid macular edema. So what we have? We have poor visual acuity. This is the most frequent complaint. The onset is usually peaked 4 to 6 weeks post-operative. Even though it can occur 2 years post-operative, it can be classified into acute within 4 months of surgery, late onset after 4 months, chronic lasts more than 6 months, and it can be recurrent. We can found on fluorescein angiography leakage in the leakage in a petaloid pattern, and also a hot disk, which can help to differentiate even if this is cystoid macular edema due to diabetes or this is a pseudophakic cystoid macular edema. So what about the OCT findings? It has a directional structural progression pattern. It usually begins in the inner nuclear layer and then involves the outer plexiform layers, then finally the subretinal space. So the disease can be classified as active disease, as we can see in these images. If there are 3-layer structure, inner nuclear, outer plexiform, and subretinal space, or if there is an outer plexiform layer morphology, and also an isolated, as picture E and F, isolated inner nuclear layer early in the post-operative period, all these are active disease. But if we found combined inner nuclear layer and subretinal fluid edema without outer plexiform edema, it is almost a resolving cystoid macular edema. Also, if there is isolated subretinal fluid, it is a resolving also. Why is this? Because the subretinal fluid, it is the last to be absorbed. This is because the fluid is sequestrated in this area by the external limiting membrane, and there is active transport of the protein of the water content through the underlying RPE, leading to hyperprotoic concentration in the subretinal space, and thus it remains until late. Also, why the inner nuclear is the most frequent layer? Because the inflammatory mediators induce mid-capillary plexus hyperpermeability, and this mid-capillary plexus borders the inner nuclear layer, leading to leakage of fluid in the inner nuclear layer first, and then outer plexiform layer, and then so. So, what about the vitreous hyperreflectivity dots? It was mentioned in one report that it was higher in patients with pseudophakic macular edema than others because due to alteration in the protein composition of the vitreous fluid, supporting the inflammatory mechanism. As we can see, these vitreous hyperreflectivity dots. The OCTA, it appears as intraretinal cystoid, cystic roundish black spaces on the core-gestured in-face images, and also there is vascular reduction, vascular density reduction. But if we compare it to the diabetic macular edema, this vascular density reduction is found to be temporary, and it quickly normalizes again. What about the treatment? We have first non-steroidal anti-inflammatory drugs. Topical is better than systemic, and steroids topical can be given in different routes. First is the topical, and the combination with the non-steroidal anti-inflammatory drugs is superior to either treatment alone. Also, we have intravitreal triamcinolone, can be used in refractory cases, but is associated with the IOP rise. Also, intravitreal Osiurdex, dexamethasone implant. If compared to intravitreal triamcinolone, it was found by Dang et al. In 2014 that ocular hypertension is more frequent with intravitreal triamcinolone, and about half the patients required intravitreal triamcinolone injection again within 6 months. Steroids can be given also periocularly and systemically, but systemically is no longer accepted. We can give also systemic carbonic anhydrase inhibitors, 50 milligram daily, but no randomized clinical trials supporting systemic carbonic anhydrase, only case reports reporting its effectiveness. Anti-angiogenic agents, anti-VEGFs are not accepted. It is a controversial. Some reports mentioned that it is effective, but these reports were retrospective, and all patients were not treatment naive. Laser can be used to lyse any vitreous strands coming to the wound. What about the surgical treatment? We have anterior vitrectomy, either through Lemper or Barzo-Plana approach, or complete Barzo-Plana vitrectomy. Of course, complete Barzo-Plana vitrectomy is not considered the first line of treatment. It's used only in unresponsive cases to medical treatment. It helps to remove the vitreous adhesions, inflammatory mediators in the vitreous, and give a great access of steroids to the posterior pole. What about the prophylaxis? The prophylaxis is, of course, more effective with topical non-steroidals compared to topical steroids, and it also only effective in cases with risk, as patients with diabetic patients or patients with diabetic retinopathy, but no benefit of prophylaxis in unrisky patients. So cystoid macular edema represents the most frequent postoperative complication. Prevention of cystoid macular edema requires a detailed preoperative evaluation. Patients with known pre-existing conditions or complicated surgery should be closely followed up. Recommendations for prophylactic not relevant except in patients with risk, as diabetic patients or diabetic patients. It can be given before and offered for a month, and offered for 1 month after surgery. So we have this best sequential management. First, topical non-steroidals combined with topical steroids. 2 minutes the presentation. Second, subtenon triamcinolone if failed, intravitreal corticosteroids, triamcinolone acetonide or Osiurdex. And if there is vitreous incarceration, we can consider YAG vitreolysis and then vitrectomy. If there is persistent inflammatory action, we can consider IOL removal or Barzo-Plana vitrectomy. No randomized clinical trials reporting effectiveness of carbonic anhydrase inhibitors. What about hemorrhagic occlusive retinal vasculitis? A very rare but potentially devastating complication. The primary risk factor is intraocular vancomycin during surgery, whether intracameral, intravitreal, or on the irrigating bottle. It is a presumed type 4 hypersensitivity reaction with intravascular thrombosis and necrotizing retinal vasculopathy. But recently it is reported following intravitreal brolucizumab. Diagnostic criteria was reported. It occurs after intraocular procedure with normal undilated examination on post-operative day 1 with delayed onset of sudden painless decreased vision. Visual acuity is usually poor at presentation, mild to moderate anterior chamber and vitreous inflammation with no hypopyon. Sectoral intraretinal hemorrhages in the areas of non-perfusion, peripheral involvement in all cases, macular involvement in advanced cases, sectoral retinal vasculitis and vascular occlusion and fluorescein angiography. Rapid progression to neovascular glaucoma, history of similar reaction in the fellow eye. When both eyes are involved, second eye has faster and more severe course. Minimal to no corneal edema. Retinal hemorrhages are often large and confluent. Propensity for retinal venule involvement. No significant increase in venous dilatation compared to central retinal vein occlusion. Therapy with additional intravitreal vancomycin associated with especially poor outcomes. So here, this is a picture, fundus photo showing areas, extensive areas of hemorrhages in the periphery with macular, with areas of whitening can be seen on fluorescein angiography. There is profound peripheral ischemia in the areas of hemorrhages, and there is increased thickening of the retina with the retinal hyperreflectivity and maybe edema in the OCT. What about the differential diagnosis? It can be mistaken for endophthalmitis, viral retinized central retinal vein occlusion. In HORIV, the eye is quiet, which is no pain. Compared to endophthalmitis, in HORIV, the vitritis is mild with no progression of retinitis compared to viral retinitis. In HORIV, the venules are not dilated compared to central retinal vein occlusion. The treatment include aggressive systemic and topical steroids, early anti-VEGF and PRP to prevent neovascular glaucoma. You can consider ocular or systemic workup if the diagnosis is unclear. Avoid for sure vancomycin for suspected endophthalmitis and vancomycin use in the second eye. The prognosis in half of the cases is poor with rapid progression to neovascular glaucoma. So reconsider vancomycin, using vancomycin with sequential bilateral cataract surgery. Surgeons desiring an alternative to vancomycin can use intracameral cefroxime or moxifloxacin. Avoid intravitreal vancomycin if HORIV is suspected. Avoid vancomycin use in the second eye. And thank you.